Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Hello, everybody. Let me start by saying thank you for the opportunity at LE&RN to talk about lymphedema and the only way to treat it. So for me, it's the most important thing that people have information all over the world. So what LE&RN is doing, honestly, it's incredible. I tell you, who am I? My name is Tim Decock. I'm a physical therapist from Belgium. I am the director of the Vodderschool. And I have 2 lymph clinics in Belgium, one in Antwerp and one in Willebroek. And out of those things, I teach a bit everywhere in the world. And like that, I can see what the differences are. I just returned today from Barcelona. It was a big congress, and over there, yeah, it was a wound congress, and they don't mention the lymph problems. So it's a bit strange. So for that, thank you, LE&RN, to help us with those things. Now, as I said, I'm from Belgium, beautiful country. One day you should have to visit it, but the weather is not as good as where you are probably. Now, this is my clinic. And what I say is the outcome of 1,700 edema therapists from Vodderschool in Belgium and the Netherlands. As they are trained, it's by the ISL consensus. What is the ISL consensus? It's the International Society for Lymphedema. Every 2 years, all the experts from all over the world are coming there. And what do? We find the best way to treat lymphedema. Now, and it's good. Every 2 years it changes or it stays. We're comparing things. So we follow this consensus, and this year there will be a new one. Now, when we talk about edema, we have to find out what are the differences. Yeah. For example, a little thing to think about. Imagine you have an ankle distortion. Yeah. Problem at your feet, and you have a whiplash. Someone bumped in the back of your car. What is the first thing we do? For the acute phase, everybody will say now, okay, the ankle, I will put ice on it. Logical. For the neck, we were trained, okay, warm is good for my neck. Now, knowing that a traumatic edema is by definition a lymphedema. What do we want to do? We put ice on the foot and heat in the neck. Now we have to think about it. What is the difference between those two? And please don't tell me it's the location. I do know that too. That we see the swelling of the foot. We see that. But we don't see a swelling in the neck. So why that different treatment? If you know that, and I will show you the sign immediately, I'll go on later. Just a second. Now, if we talk about edemas, then we can say worldwide, do we know them? Yes, even Snoop Dogg does. Can we prevent it? Now, that's still a discussion. Some say yes, some say no. So let's say it's still under construction. But can we treat it? Yes. What do we need to know? We need to know what kind of edema we're talking about. So now I go back. This was what I wanted to have. Out of our heart, the anatomy, physiology, is arterial blood coming to everywhere in our body. There's an exchange of oxygen, and it goes back to our heart. Logical system, closed system, like a central heating a bit. There is a parallel system. There's an exchange of enzymes, cancer cells, fats. But one thing is very particular, proteins. What are proteins doing? They're sucking up fluid, water, and they're transporting it totally back to the heart. So now, if we think about this system, we go back to the eyes of the foot. We want to have a vasoconstriction of the blood vessels, like that, so that the foot doesn't swell more. Now, do you think if we put on heat, then we are creating more blood coming to that injury? What is in that blood? Proteins. What are proteins doing? Remember again, that. And the difference is, don't you think that there is a swelling? You just don't see it. So the first 5 minutes you are feeling, well, oh yes, after massage, after heat, and you say, oh yes, this was great. You go out, and 5 minutes later you say, it's back. It's as worse as it was before. So it's just thinking, why do we do it? Because they learned that. They learned it like that years ago. But we have to think about, and just the same with the edemas. Yeah, we need to know what we're talking about. Okay, out of the arterial capillaries are coming, as you see, the proteins, and they are transported by the lymphatic capillaries, and a part is going back to the venous system. That's the physiology. Now, how do we treat people like that? It's an easy way. When we talk about edema patients, and most of the time, there it's going wrong. We have to do it in teamwork. And if you don't work together, you will never have beer. That's the easy way. Now, when I started years ago, 150 years ago, I think, it was just this. 2005, we had a generalist, that was a system for me. We had the physical therapist, we had the bandagist, and in the middle was the patient. We are 20 years further. There was really a big evaluation in lymphology the last 10, 15 years. So now it's a bit dead. Look how many people are involved in the treatment of lymphedema. We have a generalist, a physical therapist specialized, a bandagist, psychologist, wound care nurse, vascular surgeon, lymph surgeon, psychologist. Can imagine. If someone has a breast problem, you can imagine the importance of the psychologist, and so on and so on. Now, then we can think, is this the correct way to treat? With the patient in the middle. It's not. We don't bend over the patient. The patient, it's a bit this. Okay, let's talk or vote if we continue the treatment. And the patient says, yes, can I vote too, please? Yeah. So what is wrong? We don't bend over the patient and decide for him. No, the patient needs to be a part of the therapy, a part of the team treating. Because you can imagine if the patient says, I had a while ago a patient, and she came into me and she said, okay, I'll do what you want. But one thing, I don't wear a stocking. Yeah. And then I say, okay, then you can go out. Because you need to wear it in this case, in her particular case. And what do we need in the middle? Not the patient, the phone. We have to talk to each other. And that's a bit the evolution of the medical world the last years. Everybody's working a bit on his island. It's impossible in lymphology. We have to take our phone and call each other. What do you think about that? I will go over a list of about some medical persons, what they have to do. Okay. We call it the CDT. CDT is the complex decongestive therapy. That's the name international. I don't like the word complex. I would name it complete. Complete means everybody has to help. We all work, and as I was speaking yesterday in Barcelona at the Wound Congress, with all the nurses and the doctors, we have the same patient with a different input. But we are treating it on his own way, but we have to talk to each other. What did you do? What was your result with that? And if you cannot work together, please don't start with it. Now, let's see the generalist. The generalist here in Belgium too, what does he have to do? What should he have to do? Most of the time, a lot of them don't recognize edema. Yeah, a lot of patients don't have pain. What is the most known? A swollen arm after a breast operation. This is the most known, and they will see that. Now, what to do with that? Okay, you go to the physical therapist. Yeah, which physical therapist? Yeah, physical therapist is a physical therapist. No, it's not true. It's specialized. Now, he has to refer to vascular surgeons or lymph surgeons. He has to recognize the edema. He can do already an ECG. Why? If the patient has a heart problem, then is the moment to give diuretics, not for a swollen arm with lymphedema. He can do a blood collection already, and diuretics, as I said, only with generalized edema. What is the role of the vascular surgeon? Refer to the lymph surgeon, radiologist, specialized physio. Recognize the edema, diagnose, make a diagnose. They do a Doppler, check up arterial and the vascular system, just to find out, is there a thrombosis, yes or no? Yeah, and of course they do surgery too. Vein operation, arterial operations, foaming in case of venous edema. The lymph surgeon or the plastic surgeon, they refer to the specialized physio. Surgery, lymphovenous shunts, they treat malformations. Recognize the edema again, make a diagnose. As we work with the plastic lymph surgeon, as Professor Campisi, for example, it's incredible to work with those people because they found out what is the problem, and now we can go on. Yeah, every country has specialized professors lymphology. We need to know them. We need to contact them. What is the role of the bandagist? Measure stocking in a perfect way when the lymph is decongested. Another thing too. And I see it a lot, that people come in and there was a stocking measured on a thick leg. No. Remember, we have to make it thin. The stocking keeps it thin. So measuring a stocking on a swollen leg, that's not a good way. It's going down. Okay. What else? Lymphedema, flat knitted stocking, venous edema, flat or round knitted stocking. The difference is that the flat knitted is a personalized stocking. Yeah, a round knitted can be off the shelf. Yeah, they measure too, but it's not completely for that leg. So for a lymphedema, always flat knitted stockings. They have to refer to specialized physio when it's not decongested enough. What is the role of the wound nurse? Specialized wound care. We need it. I don't know a lot about those things, so I need those people. Not wear long stretch bandages. It's short stretch that we need for an edema. Why? Honestly, if we have an edema, we have to stimulate, no, support is a better word, to support the muscle pump. Meaning our skin is doing that. Our muscles are pumping, yeah, but our skin is very elastic. So we have to make a tube around it. It's a tube that doesn't stretch a lot. So meaning now our muscles are doing that. Specialized physio. A very important thing, and I know how it happens. I'm a physio myself, as I said, and I tell my students that too. Make sure that the patient, when he goes out, knows what's wrong with him. The patient needs to understand. So my first hour is measuring, talking, yeah, things like that. So the patient knows what the future will bring. What will it cost the patient? What will we do? Things like that. Give the patient an insight. And then it will be an overview and a view. We have to bandage. Bandage, and I keep on saying it, it's an art. What is the stupid thing about it? When we do it well, then people say it's normal. When we do it wrong, then it's bad. So it's an art. We have to do that correctly. Specialized manual lymph drainage, evidence-based, mobilization, exercises, and general condition. Don't let those patients sit. They have to work. They have to train. Lymph taping, make it soft. A heart edema, you can make it soft by taping. And measure. Make sure you have enough data to go further with your treatment. It's not for me. Yes, it's for me too, but also for the patient. If you see an evolution with it, that stimulates your patient. And you will be happy. And you will continue as a patient then. And you can send it, of course, the patient, of course, to a vascular surgeon or lymph surgeon. Now, if you notice now, if I make a resume of all those disciplines, what did we see? Diagnose and send. Meaning, we have to do it together. Me as a physical therapist, I need this lymph surgeon. Yeah, in my clinic, I work with Dr. Giacalone. I need these guys. I work with my vascular surgeon. I need these guys too. We have to work together. Now, what are the possibilities to treat edema? First of all, as I said, the intake, bandaging, evidence-based manual lymph drainage, mobilization, exercises, and measurements. Now, about that intake, the quality of the intake guarantees the way of loyalty for the patient. The patient, if the patients understand, they will be good for the therapy. They will follow your therapy. Because imagine the one is the patient and the other one is me. We are both right in this case. Yeah, but perhaps we don't understand each other. I had a patient a while ago and she came in and she said, Tim, it's almost winter. I want to fit in my ski boots. That's all that she wanted. So I said, I want more, of course, because honestly, as medical people, my hands start to itch already because I want to fly on that patient and treat. No, listen to that patient first. Yeah, she wanted to have the ski boots. Okay, I said, you know what? We make that our first goal. The patient said, okay, good. You want more? But if I can do that already, I believe you. So let's look at it that way. Because for the patient, it looks so incredibly difficult. It's not. We only have green, red, and orange. Now, if I look at the lymphedema, the Lymph pathway by the International Society, everybody knows we have two phases: decongestion period, maintenance period. What do we do in the decongestion? Skin hygiene. Very important. Control, measurements, intensive MLD, bandaging, and exercises. After a few months, when it's a bit continued, it's a bit stable, skin hygiene stays. Control, maintenance, decrease the MLD, and then it's the stockings. And of course, self-management. Self-management means the patient needs to move. The patient needs to walk, swim, things like that. The patient needs to wear his stockings. Yeah? The patient needs to watch out for food. Patient cannot come like that. They have to watch out a bit for their figure. So it's not they have to go on a diet, but they have to live healthy. You can imagine if it's a venous edema and you keep on smoking, it's not the best way. We all do know that. So self-management is a very important one, but you can only do that if you have the patient on your side, in your team. We need to understand which kinds of edema do we have. We have generalized edema, venous edema or flap edema, lipedema, and lymphedema. Let's go over it very fast. The venous edema, what is it? Most of the time, what disorders can we have? We can have an obstruction, inflammation like phlebitis, a thrombosis, not that good, of course, yeah, compression, by tumor or by May-Turner syndrome, for example. Most of the time, it starts with valve insufficiency. So meaning your heart is pumping down everything to your legs, and then it goes up, and every the valves are closing. Yeah, a lot of times, yeah, perhaps you're a little bit too heavy, you smoked here, you had a few pregnancies, you took the pill for some years, things like that. What's happening with those valves? They do that. They don't close completely. So the heaviest thing go down. What is dangerous for that? That it can become a thrombosis. So most of the time, that's the cause of that problem. We can have a post-thrombosis syndrome. Post-thrombosis syndrome means that the valves are destructed for a part, and chronic venous insufficiency. Now, what is that venous system? Honestly, it's a blood reservoir. The venous system contains 64% of our blood volume. The driving forces, muscle pump, respiration, and the remaining arterial pressure from the heart, that has to go up. Muscle pump and respiration. And there we go again. We have to move with those patients. We have to walk. They need to have the pump work in their legs. As you see on this man lying down, and we all know that. When somebody had a heart operation, the first thing they say is, you have to move your feet. So we know it. Why wouldn't it be different for edema? Know that it's gravity independent. Yes, it's an American, Willie Coyote. So it goes down by gravity. What is the treatment? Elevation, respiration therapy, active physio, muscle pump, work, train, passive physio, lymph drainage, bandaging, pressotherapy, and compression. Those patients need, if the valves are doing that, they're not closing anymore, and we put compression on it, now they're closing again. We need to give them immediate compression. And of course, in last possibility, surgery. Why do those patients have to walk? It's a pump of Gardner and Fox or the sponge of Lejar. If you look at the feet, look, it's a sort of a pump in the sole of our feet. It's a venous pump. Look over here in the under part of the photo, you see that the veins are filling completely. Now, if you put down the foot, they're emptying. So every step you do, it's that. And you're pumping everything up. So it's necessary to do that. How do we recognize venous edema? Most of the time, the skin is changing. Yeah, it's better with elevation. Most of the time, it's distal, meaning the under part of the legs. Yeah, and there is a strong pitting, meaning if you push, yeah, and you keep it a while, you'll see that the pit stays on the leg. Yeah, it's beautifully described by Håkan Brorson that says, at maximum, we need to push for 1 minute. Most of the time, generalists don't see it all the time, so they don't push long enough. Now, treatment, what is happening physiologically? You have to understand this. There is a venous hypertension, so the pressure on the veins is so hard, so the proteins are coming out. Yeah. What will it have? It becomes edema, and it will become a wound. What do we have to do? Very simple, compression on it. Yeah. Always compare it this way. Like that, everybody understands. This is a vein, your venous system. This is your lymphatic system. And this, I needed a hand extra, this is the area in between. So what's happening? Out of the veins are coming all those proteins. The smallest go back, but most of the part, the proteins suck all the water from in between, and it's transported by the lymphatic system. Now you can imagine, where is it going wrong? Is it here? Is it here? Or is it here? You will see me do that a few times today. So this was a patient On Tuesday, you see the left leg that is swollen. There is it's a bit colored, the skin changed, and 2 days later, it's totally gone. So we had a good bandage, and now we can wear a stocking. The reflux of the venous blood is prevented by a system of valves. And most of the time, they don't work as the photo on the right side. They don't work anymore. Generalized edema. What is generalized edema? Generalized edema, like that. You can see pitting. Sorry, I talked too much yesterday, I think. Generalized edema, you see the pitting. You see where the socks were and the shoes, even that. So generalized edema is caused by heart failure, enteropathy or the intestines, nephropathy, the kidneys, and mixed edema, the thyroid gland, which is failing. What do those patients need? Diuretics. So the physical treatment of generalized edema, not for us. You can imagine if the legs are thick, compare it. I always try to say it very easy. It's a bus, a school bus, and in those school bus, they have put a small engine from a Mini Cooper. It will work, but from the moment you have to drive a little bit upwards, it doesn't work anymore. So it's a bit like that. So if we do a drainage on those legs, then you can imagine that we are drowning that motor. So it's the same as driving upwards. And most of the time, it's a contraindication for physical treatment. And if not, it's useless. We can move the liquid, but never evacuate. So it's a small part for us. Remember, only diuretics for generalized edema. Lymphedema. Lymphedema, it's a terrible definition. What do you need to understand about lymphedema? It's not a water problem, it's a protein problem. How? By a failure in the transport system. Dot. If you remember that, then it's okay. A protein problem and transport system is failing. Where is it? It's very on the surface. If you see that the epidermis, that's the skin. You see the fat on the photo and the muscles. The under part is the muscles. And it's right under the skin. So if you have a burning, for example, yeah, what is it touching? It's touching your lymphatic system. If you cut someone, you cut the lymphatic system. The lymphatic system, the lymph vessels, they have valves too. You see that from valve to valve is called the lymphangion. How is it working? To the influence of the neurovegetative nervous system. What does it mean? Yeah, it's difficult like that. Okay, if I think, Tim, put your arm up, then I can do that. But if I'm hungry, I cannot say to my belly, now make a noise. That's the neurovegetative nervous system. The lymphatic system is working on that too. The containment of the water is 96% of the water of the lymph is 96% water. Minerals, dead cells, cancer cells, enzyme and proteins. 3-4 grams. It's a lot. Now, what can be wrong with that lymphatic system? It can be primary, it can be secondary. Most of them we say is the secondary, of course, but primary, yeah, there are missed a lot of times. Yeah, it can be congenital by birth, hereditary. Yeah, and Precox data is a very old way of making a definition of the system. If I put that on a screen, I need 5 screens extra. It's changed so much, but I keep it in my list here because it's easy to explain to the patient. Yeah, it's a primary lymphedema. Precox mean at young age, puberty, for example. Tarda, most of the time, it's after 30 years. It's not common anymore now. It's not the new days, it's old school. But remember, it's easy to explain to the patient. Now, the secondary lymphedema, most of the time by obstruction, surgery, radiation, and cancer. Yeah. In the exotic countries, it can be inflammation. We see that too, of course, but lymphangitis and filariasis, we don't see that a lot. In the southern countries, such as Africa, we see that, and it's thanks to the Culex moustique, I think, yeah, who puts her egg in our lymphatic system. I saw it, I think, here in Belgium. I saw it 2 times, and 2 times it was a stewardess who went to the tropics. So, needing that, we need to find out where is the problem. Treatment of lymphedema. Manual lymph drainage, no rest elevation needed if it's only lymphedema. Sometimes we see a patient with a very swollen arm, and then they say, we ask them, is it better in the morning? And they say, yes. How does that come? Because of the arm is swelling that much that it's compressing your venous system too. And that's why it's better in the morning and keep the arm upwards. For the lymphedema itself, it doesn't do a thing. Exercises, bandaging if needed, lymph taping. This was one of the first doctors, as you see, it's black and white picture. It was in Argentina years ago, and the doctor said, now imagine if I take off the skin and I let the water going out, and it's a goal for me. He forgot one thing, the water was out, but all the proteins were still in there. So he made it again, the stitches, what happened? All the proteins did that. They sucked up the water and everything was ting, ting. So he didn't do it a long time. But we learned a lot of it. How can we see it's a lymphedema? A stemmer test. The stemmer test tried to take the skin fold. It's developed by Kaposi Stemmer, France. And they take the skin fold between the second and the third toe. But you can do it everywhere. You see, I can take my skin, yeah, but sometimes, and you see the stages, like this, for example. Okay, stage 1. You can take a skin fold and it's thick, but you feel that your fingers are going closer, a bit like butter. Yeah, so it's reducible. Stage 2, not reducible anymore. Stage 3, you cannot take a skin fold. And stage 4, it's so hard. It's almost elephantiasis. This is a lymphedema too. Yeah, please don't bandage. Lipedema. And I have put this today extra. It's not obesitas. Yeah, we have to find out, is it really lipedema? Because a lot of colleagues are treating obese patients. It doesn't work. And after a while they say, no, this therapy doesn't work. How do we recognize it? It's always symmetric. Yeah, they have quick hematomas. If you just touch them, they have an hematoma. It's never at the feet. But one thing is very important. They have pain if you squeeze their legs, yeah, or their butt. If you squeeze it, it hurts a lot for those people because of it's a fat problem. Yeah, the develop of the fat is different. It's wrongly organized in there. So what's happening? The fat is inflamming. Yeah, and it's swelling all that much. So they have a compression from the inside to the outside. So if you touch from the outside, yeah, it's a bit if you drive with a motorcycle to a wall or 2 motorcycles, 100 kilometers an hour. It's miles an hour in America, I know that. So the collapse, the impact will be a lot bigger from the 2. So, and that's a bit what's happening with those lymphedema patients too. They're always hypermobile. You will see that at their knees. Okay, what are the stages? Thickening of the legs, smooth legs, tiny tissue knots. 2, skin surface is uneven. Yeah, another fatty tissue structure. And the last stage is a total lipodystrophy. So it's a bit like that. And now you say, yeah, but that left photo. Hey, I know a lot of people who has legs like that. What is the only difference? hematomas, blue spots, and pain. And it will become the third after a while if you don't do anything about it. Now, what can we do? Again, over here, it's multidisciplinary approach. Yeah, MLD to reduce the pain, good MLD. Compression, dietary measures. There was an investment or a research about keto diet with fantastic results. So they're still developing it. Sports, and before the age of 35, you can do a lot. Surgery, of course, liposuction in the worst cases. In some countries, they do immediately a liposuction, but don't forget, it takes away the lymphatic system too. So honestly, the best would be to do a lymphoscintigraphy to find out where is the deep system, a fluoroscopy for the superficial system, and then go between it. That would be the best way if you do a liposuction. Otherwise, it comes back. It's a stimulation hormonally. This list is a very important one. Please keep it, because like this, we can find out, is it general, primary lymph, secondary lymph, venous edema, or lymphedema. This is the most important list. Even put it on your desk and do those tests. The pitting, yeah, for generalized edema, a lot. Venous edema too. Yeah, lymphedema only in stage 1 and beginning of stage 2. Lymphedema, if you try to make a pit in their legs, they will hit you because it hurts. The stemmer test, for example, stemmer is only positive for lymphedema. Pain, most of the time lymphedema. Look, and you have to look at this list completely. Is it bilateral? Generalized edema, if you put them on their both feet, it will be both legs. Yeah, that's why it's only 1+. Lymphedema can be. Secondary can be. We can have 2 breast operations, for example. Venous, I don't know. If I have varices on the 2 sides, yeah, lymphedema, always 2 sides. Distal, meaning the under part of the leg, yeah, for generalized, depending from gravity. Primary lymphedema, mostly the under part, yeah. Secondary lymphedema, depending where the operation was. Where did they take the lymph nodes? Yeah. And then lymphedema, it's never at the feet. Does elevation help? Generalized edema, yes, you can be sure. Venous edema, yes, you can be sure. And why is there a little plus with the primary lymphedema and the secondary lymphedema? Those are the patients who have so much swelling that it's compressing your venous system. Okay, and lymphedema, it doesn't work. Is it symmetric? Go on with this list like that. Find out, and you can make. Now, what is the difficult thing? It's seldom that it's only one. Most of the time, it's a mix from 2. You need to find out. What is very important? Bandaging. Bandaging, we need to use the correct materials and do it good. This was one of the first people who bandaged. It was Professor van der Molen in the Netherlands. It wasn't the best technique, but we learned a lot about it. Which kind of bandage? For lymphedema, always a short stretch. Why? Yeah, the resting pressure is low, meaning, okay, it's difficult. What is stretching a lot can endure too. And we need to make, as I said in the beginning, we need to make a tube, a stiff tube around that leg, so like that we support the muscle pump. Yeah, it cannot go that, like the skin. So we need to make a short stretch. Does it mean you have to throw all the long stretch away? No, but remember that you have to put 4 layers, one above the other, to have a short stretch. So you can use them, but the leg is getting thicker and thicker, or whatever you bandage. What are the objectives? We want to stop progression, volume reduction, avoid complications, improve functional disorders, and we have to reduce filtration. Look, we don't want to impede the blood circulation. Pressure, we want to push it upwards. We have to protect sensitive places. Bandage fingers and toes always. And we can have a gradation of pressure by decreasing the overlap. These are patients that I saw. It was by a bad bandage that this happened. We can create things like that too. And don't forget, for a lymph patient, we can create erysipelas. Yeah, what is it? There's a hole and bacteria are in it. Now, don't forget, our lymph system is our immunity system. The better our lymphatic system, the stronger we are. So try not to do that, because if you know, bacteria are everywhere and they're hiding. It's a great picture. We have a lot of choice. Yeah, I have my preferences for bandages, but we need to know, what do we want? Yeah, we want not to slip. We want the patient as much comfortable as possible. Yeah, he has to go in his shoes, not the shoes of the husband. No, those are the things, and it has to work very good in acute phase. Now, measure. How can we measure? We have the measure tape. We have the PeriKit. PeriKit is a new device that's developed, and it's with an app, and you can show graphics to the patient. Incredible for the patient. We can use the moisture meter, which is measuring the lymphatic system. A scan which they have in hospitals, is extremely expensive. Lymphoscintigraphy, and I know we do it a lot in Belgium. And the lymphofluoroscopy. The lymphofluoroscopy, they inject indocyanine green. Indocyanine green is taken by albumin. Albumin is a protein. Proteins are transported by your lymphatic system. So like that, we can see it. Now, why do we have to measure that much? One, make sure that the treatment is working. For us, for the reimbursement, you can report to the surgeon. But most important thing is, you can stimulate the patient. The patient needs to see, is it better, yes or no? A while ago, I had a patient, and the patient was treated for, listen well, 9 years by the physical therapist. Yeah, I was not so happy with it, and the arm was incredibly swollen. And I said to the lady, is it better? And she said, no. Yeah, it was measured. No, never. Yeah, how can you know that it's better? But the physical therapist says it's softer. 9 years, 3 times a week. And it became all fat, because the stages are water, fibrotic tissue, fat. And it was there. I cannot do anything anymore. So the only thing, if we wanted to help her, was liposuction. What is that PeriKit that I show you about? This is the measuring tool that we use over here. What is the moisture meter? The moisture meter is a little scan that's measuring the percentage water content just right under the skin, meaning our lymphatic system. Was it good? Yes. I used it with my team to do a pilot study. Yeah, because we wanted to know, is there a changement after lymph drainage? Has to. Otherwise, lymph drainage doesn't work. So we did one treatment. The target was MLD, yes or no. Yeah, and we had to measure always on the same spots. We included all patients with lymphedema. We excluded patients with venous, generalized, or lipedema. And we compared a lymph drainage on lymph patients and a massage, a good sport massage. I didn't do that on lymph patients. Otherwise, there was a danger of swelling. But it didn't matter, because I would have a change on the lymphatic system with a normal massage. So these were my standard points on the dorsal side of the foot, 5 centimeters above the malleolus malealis, malleolus medialis, and so on. Yeah, measured before and after the MLD. Conclusion. For 22 patients, there was a difference from 5 to 10% before and after MLD. For 8 patients that I did, a small pilot study, With the massage, there was only a difference of 0.1%. So with the MLD, we did make a changement. With the massage, we didn't do lymphatically. That is the lymph scanner. It's an easy tool. Now, about bandages, I love to use the Coban 2 layer. And I try to compare the multi-layer against the Coban. Which one do I prefer and the patient? So what did I do? I measured the time. Okay. So it was shorter with the Coban. Don't forget, if the patient has to come back, we have to roll the bandages again. Coban we cut. Yeah. I tried to ask for the comfort. And Coban was more comfortable, or the 2-layer. I'll call it like that, not to mention a brand. And the material cost, now I say, yeah, but that Coban is expensive. Is it? If you work in a hospital, the multi-layer, there was an investment in Lausanne in Switzerland, and it keeps its pressure for only 4 hours for an active person. The Coban or the 2-layer cohesive bandage keeps its pressure for 4 days. Now, if you can treat your patient every day, good. I don't have the time for it. And the cost is a lot higher for the multi-layer. Okay, not the materials. You can use it again, but they have to come to us to bandage again. And that's costing money too. Now, what are the pros and the cons? The pros about multi-layer is in acute phase, there's a good reduction of the edema, economically interesting, easy to find. Cons, takes time, uncomfortable, thick, yeah, warm. It slips very easy, and we have to do it 1 or twice a day. The 2-layer, incredible for fast reduction, easy to applicate, easy to learn. Yeah, it's more comfortable, fits perfectly under clothes and in shoes. It's cost effective. It stays on for 4 or 5 days. The con in Belgium, and I don't know in other countries, the patient has to pay it himself. Yeah, and it's not reusable. What did that mean for me? Yeah, more time to do exercises. The bandage. I could, use my time for other things. MLD above the bandage was a possibility. Yeah? Taping above the bandage was a possibility. And a lot more patients could be treated because I only see them every 4 or 5 days. What did it mean for the patient? Better functionality, higher comfort, less time investment, and less slippage, because that is hurting. Now, what was important for me too, and I didn't put it between, as I teach students, it's easy to learn. And that's important for me too. Okay, it was thanks to Professor Hugo Parch. They did a research, and the best thing was twice a week to change to keep the most effective pressure. These are the things I see. I don't love it. This was a bandage who started above the ankle. Yeah, well, you see already, this was a diabetic patient. You see what it did with the foot. And now you say, how is it possible? It still happens. Now, MLD, yes or no? I have a few patients. This was a patient, let's see if there's a pitting. The patient was treated already, but only with bandaging and exercises. That's good, but they never did the MLD. So was there a pitting? Yes. Stemmer. Yeah, I couldn't take a skin fold. Yeah, it was hard to take. It was so hard. So the tissue became fibrotic. Yeah? What happened over there? All those proteins, they pushed that aside and they stayed here. What is happening? It's becoming a fibrosis. After the MLD, look, I could take a skin fold now. So the patient could move a lot better because the legs were not only thinner, but yeah, they could move again. Patient 2, the swelling at the foot, we see it off. Yeah, it's hard to take a skin fold. one treatment. Stemmer, negative. So look from that foot, look, one treatment. We can all do that if treated in the correct way. Now, what did we do? We did the research by 500 therapists, and we measured before and after treatment. One treatment. Yeah? The treatment is described completely from begin till the end. And now I say that too. I hear a lot, MLD doesn't work. What is MLD? That's why we described what I had to do, which pressure, which technique. And now we can say, okay, it's working, yes or no. I included only secondary lymph patients with pitting, acute phase, positive stemmer. I excluded all the others. Yeah, I had 611 measurements. Honestly, it was my students over a few years. And as an end project, they had to do this. So it was all different therapists. I excluded 168 patients, including 443. And we measured them. The first group, we had an improvement from 8 centiliter till 75. It's a bottle of wine. Huh? It's almost weekend. Huh? Okay, so that's a lot. One treatment. The second group was not with the pedikit, but it was with the tape line. And we had from 1% till 6.63. So it's working very well. Is it enough? No. They have to wear stockings afterward or a bandage to keep the result. So if someone says, I only treat that with manual lymph drainage, it's not enough. We have to make the compression complete. Okay, MLD, specialized MLD, I call it MLDV because I'm from the Vodderschool. So gives an improvement in one treatment, if done in a correct way. So what is my goal during the rest of my life? Of course, physios needs to be trained for that. It's not the soft touch anymore from years ago. I was trained like that too, but it changed a lot. Thanks to the fluoroscopy, the lymphoscintigraphy, we could develop our techniques. Ask the patient for a goal. Every treatment is individualized. Every patient is another patient. Don't treat every arm the same because they're all different. Yeah. Is it the total breast which is gone? Did they take all the lymph nodes? I don't know. Yeah. And a very important thing, criticize yourself. I do try to do that too. If you don't have a result after 10 treatments, look for a solution. The ISL consensus says if you don't have a result in 3 months, you have to look for a solution. Honestly, we see that result after 10 treatments. If it's not better, nothing, please search for help. Call someone. Yeah, measure correct, like that you know it's better. And know that only MLD is not enough. Compression is an obligation. So these are the things that I was talking about, the decongestion and maintenance phase, and please work together. Yeah, I show you some patients, and then we can go on to questions. So that was a patient, and he had for 30 years, I have legs like this. Nothing works. I once had MLD. Yeah, it changed, but it came back. I once had stockings, but they were slipping. Yeah, what went wrong? So this was the patient. This is a primary lymphedema. And then he said, but a few times a year, I have flu, and I go to the hospital, and there they give me antibiotics. As far as I know, flu is a virus, and antibiotics doesn't do a thing. So the person had erysipelas. So I measured, and let's take the 20 centimeters over here. It's 480, the thickest leg. And after a while, 20 centimeters, it's 300. So the patient lost 18 centimeters. And he looked like that after a while. Wearing stockings, classification 6, meaning two classification trees, one above another. Because a flat knit is only going till classification 4. He should have worn his toe pieces too, but it was the government who paid it, and they didn't want to pay the toes. So from time to time, I bandage him. This was him. And now if you look well, yeah, we can see he had a venous problem too. We couldn't see that before with an echo. And a lot of skin. Please. There was one who said, I can operate that. I said, please don't. Patient 2 was a child, Sam. He had twin syndrome. So during the pregnancy, his twin brother, take it easy, took all the food. So thanks to the medical team, the baby was rescued by birth. But what left was a swollen arm. And they said, okay, if this is the only way, let's do it like that. Let's keep it. So the right arm of Sam was completely swollen. Now he became 9 years. And he said, Mama, Papa, why am I different than other kids? I cannot play with them. And what's happening? So the parents came to us. What could have happened? Let's think together. Primary lymphedema. What did they use to save the kid? Yeah, infuses. The thrombosis could have been one. So I called the professor in the university hospital and said, this is the problem here. Swollen hand, swollen arm. What can I do? Okay, Tim, you can start already, because if it wasn't a thrombosis, and indeed they found it, it was right behind or behind the articulation, the clavicula. So they found it over there. Nobody did before. So, but it was, of course, it became a scarf. So it wasn't a problem. I couldn't do anything anymore. What happened? I could bandage him, and it was a lot better. So this is so the arm was quite normal. For 70%, yeah, we decongested it. But the hand stayed thick. So they did a PTA, an operation, and the hand is since then decongested almost completely. Teamwork is the cue of the key. Patient 3, a lady with primary lymphedema, age 51. It appeared during the menopause. So you see the left leg. Okay, I measured. Is there a pitting? Yes, there is a pitting. Yeah, oh, yes, there's certainly pitting. So I worked hard. Yes, pushed all, imagine again, venous, lymphatic. I pushed all those proteins. I released them and then drained them away softly in the lymphatic system and then bandage. After a while, the leg was thin and I could even see, let's say 20 again, that's a good number, 320 and 270. So that was 5 centimeters down. It was a skinny lady, so 5 centimeters was good. And afterwards, a stocking. Afterwards, she got genital edema, and that was operated with a lymphovenous shunt. So what was MLD? Compression, Coban 2, stocking, exercises, self-management. I can go on like that. This was a venous wound. The venous wound, how did we do? MLD above the wound and a good bandage. And it was like that in 5 weeks. I go quickly over it. Venous wounds. After a few weeks, it was closed. Genital edema. We see it a lot. Prostatectomy. Yeah, we have to bandage these patients. And we can help them. Look, it's changed completely. You see skin folds again. For the patient, it's a terrible problem. You have to imagine, and it takes 2 days, not more, but bandage in a good way. It's, as I said, it's an art. You have to imagine prostatectomy that, yeah, those patients, it's finished. This was a young man, finished with sexuality, problems with it. And then it's completely swollen. It's a bit the same as a breast operation for a woman. This is our male thing. Yeah, a breast is the female thing. It took 2 days. Yeah. This patient came with 2 legs swollen completely. It's a bit elephantiasis. Now, what was it? How would we treat it? Would we start with it? He was sent by me by a generalist. He said he has lymphedema, he said, because he's too fat. As far as I know, it's not a reason to have edema. So I send him, this is yellow nail, look. So I send him first to the cardiologist because it was 2 sides. Was it a generalized edema? No. I send him to the vascular surgeon. Is there a thrombosis? Yes or no? Because I have to stay on that. No. Now, what was it? It was a lymph problem. This is hyperkeratosis over here. So we treated him 6 weeks, every 5 days, a new bandage. We had, with the MLD, we had to make the hard leg soft and then the bandage. This is what happened. It's the same patient. And he's still obese. So it was not a reason. Wrong. Wrong. Certainly wrong. And this I don't love either. You make injuries with that. So we have to do it correct. Bandaging is a very good art. You have to do it well. Lymphedema careway is a multidisciplinary approach. Measure a lot, please. And teamwork is the key to success. We start with the first international course in Switzerland with Professor Campisi, where we train lymph therapists. We start up in September now. It's physical therapists specialized in lymphedema. And we're starting a course for nurses too in a while, that they know all about this problem. Thank you for your attention. And these are, of course, the references where you can find them, where I did put everything, where I got everything out. Okay. Are there questions? Yes, I can see it. Let me see. So for those who have lipedema that went undiagnosed for many years, and lymphedema becomes part of the story, and general edema is also hereditary, how do you propose it should be treated? Well, if it's generalized edema, we cannot do a lot. We have to take the diuretics. Yeah, and if the general problem is solved, for example, the heart problem, then we can treat. But otherwise, we have to stay off. Even watch out with the bandaging. Watch out with that too, because you're pushing it all upwards. We need to know what is the problem. We need to solve that generalized edema first before we can start. I'm checking out, I live in a country where it's claimed that there is no medical evidence for the benefits of manual lymphatic therapy. I know that there is. Where can I find medical research evidence to support my position? Or do you know about a specific study or studies? Yes. Please send me a mail. I'll send them all to you. There is more evidence that it works. The last one was from Romain Barbieux. It was at the Vrije Universiteit of Brussels. This was the last one, I think, 23, 24. It's an incredible investment. And there they say, we need to do it. Yeah, and then again, what I say, what is MLD? Never they describe what to do. What is MLD then? What is sport massage? I don't know. I know what I do. I know what my students are trained for. And I know then that it works. Let's see further. May we have the slides? Yes, it's filmed. Everything is filmed. Discuss the lymphopress. Okay. Always a good question. Thank you for those nice questions, by the way. The lymphopress is moving water. Look, I'm back again. I think when I died, they put me in the ground like this one day. what is it doing? Yeah, it's not working on your lymphatic system. It's working here. So all those proteins, you push the water in between the proteins, you push it upwards. So that's good, but the proteins stay. It's a bit the same as the doctor in Argentina who let leak everything out. So that's what you do with the lymphopress. Is it good to support? Yes, but it's not manual lymph drainage. Yeah, a manual lymph drainage means that it's based on a peripheric stretch reflex, meaning we have to stretch in the length, depth, and width. And then it's doing that. And then it's contracting. Yeah? So we have to, and that's why manual lymph drainage is so specific. So, and if you do only that, it's good for your blood system. For venous edema, it's good. For your lymphatic edema, it's a good support, but it's not to replace the manual lymph drainage. How do you bandage above the knee if using Coban? You just go on till the groin, till the cross, but then you make a hip spica around the patient. Send me a mail, I will show it to you. My mail is tim.decock, D-E-C-O-C-K, @telenet.be, but I think the people from LE&RN can give it to you, and I will send you photos how to do it. Is it possible to have both venous edema and lymphedema? Yes, it's possible. It surely is. And a lot of time, and I don't know why, sometimes a lot of people, if you walk around and you look at people's leg, then I think, oh my God, they are thick, those legs. But then perhaps a generalist says, yeah, but your mother had it too. And it doesn't hurt, so it's not a problem. But it can become a problem. Varices is a venous problem. Yeah, it can be a primary or secondary problem too. So we need to solve both. I think I'm almost ready with the question. Is the measurement show only a difference? If the measurements show only a difference of 2.5 centimeters at multiple points of lymph during diagnosis, do we still bandage? I would say yes. And look, after one bandage, after one time bandaging, did it change? Yes or no? Because we want to do that right before we measure a stocking. We have to make it as thin as possible. Afterwards, now, and sometimes I see that too when I talk about the whole leg, I bandage and it's getting thinner and thinner. And one moment the body says, I do think so, it worked like that. The body says, now it's finished. And then I let the bandages come to measure a stocking. But perhaps in 3-4 months, we start all over again. And perhaps we can make it thinner again. I think after a while, it's a sort of an equilibrium that stays. Yeah. And in a few months, we can go further. That's happening too. Okay. Oh, so many questions. Is MLD safe for ongoing cancer treatment patients? It's proven by Professor Piller and Paget from Paris, Piller from Australia. We cannot make metastasis. We cannot make a cancer even worse. We cannot metastase cancer problems. Now, of course, if there's a cancer at one place, I don't work on that part, of course. But is it safe to treat on other places? Yes, that's proven. Okay, one question to go, I think. I have lymphedema since spinal decompression surgery. It's gotten progressively worse and I can barely walk. I have venous ultrasound and other scans, all inconclusive and no treatment other than massage. Both manual and the pneumatic machine I use daily. I can't walk and the pain in my feet is intense. My life alone I live alone, excuse me, and can't bandage or use socks. Someone comes to rub my legs daily for the machine. Other treatments, drugs you can suggest. That's terrible, in fact. I do agree. And you know why? You don't walk. You don't have the muscle pump. So it's so hard to do things like that. You cannot put on a stocking yourself. Yeah, you cannot bandage yourself. It's so difficult. And again, that's a multidisciplinary approach. The only thing is you need help from someone. Yeah. And you need to be retrained again. Because if our muscle pump is not working, do you remember, for example, when a patient had a breast operation, years ago, the doctor prescribed manual lymph drainage. Yes, it's true. Now they say, no, shoulder mobilization. And you know what? They are right. Because my arm needs to work completely. Otherwise, I don't have a pump over here. Imagine, I do only this. It doesn't pump in my axillary gland over here. We need to have it complete. So, and it's the same for you. Sorry to say it, but you need help from a group of people. Yeah. Okay. It's confusing. Which kind of MLD do I have to do? You know what? I don't talk about other therapies. I just know that I do the Vodder therapy, but it changed so much the last years. We made it harder. We worked harder because it was necessary. And again, that's why you need to know where is the problem, here, or here. So they all work, I think. Yes, I really do. But I cannot say that one is better than the other. But go to a specialized therapist, that's for sure. Okay, so many questions. You talk about leg, but not arm and hand. Yeah. Do I need to do both sides? Even I have lymph nodes out on one side. If there is an edema, yes, you need to do the both sides. That's for sure. Then if not, you know what? Years ago, can we do it to make sure there will be no lymphedema afterwards? I do think the taxpayer, it would be good, of course. Yes, it would work. Can we treat patients before we have an edema? I do think it works. But does the mutuality in our cases, or the healthcare, do they have to pay for that? You know what? I don't go to the garage with my car if I had no accident. It's a bit the same. Would it work? Yes. But does it cost a lot of money for the taxpayer? Then I say yes again. Yeah. It's always a difficult one. In an ideal world, yeah, where nothing costs anything, I would say, yes, please do it. After the operation, start with MLD immediately. But it's not an ideal world. Yeah, the lymph taping, for example, what is it? Oh, look it up. You will find enough at the internet, but it's to make the edema soft. It's lifting your skin a little bit. Yeah, so the fluid under it goes better. So it's good for scars, for fibrotic tissue. It's good for those things. But you will find information, or you can send me a mail and I will send it to you. Okay, I answered most of the questions. I think it was great. LE&RN, people from LE&RN, thank you for the opportunity to talk for all of you. It's so important that we treat in a correct way and that we work together. It's the only way. Okay, thank you everybody. Bye, and greetings from a cold Belgium.